So first of all, let me thank the organizers for inviting me to talk to you on this topic. All of us know about the huge problem that we are facing, that anyone or everyone can have diabetes at their lifetime. And these are some data from the IDF latest World Diabetes Atlas. Um, where 1 in 10 adults all over the world might have diabetes. And then also it comes to, again, very high number undiagnosed. We saw this even in our data initial screening for the eye health study. And also many adults having impaired glucose tolerance, impaired fasting glucose, and a lot of live births affected by uh, mothers who have diabetes during their pregnancy. And also the amount of health expenditure on a global scale is enormous. And you can see the latest diabetes map. Few things that I want to highlight is that we mainly focus our research on this region, the South Asian, or what you call the Indian subcontinent, where if you look at the data, particularly the rise of diabetes, particularly now, we all know that diabetes had been quite low in Africa because of the socio-economic condition, which is fast rising with the change of their demographic landscape. But apart from that, in other areas, South Asia has one of the highest increase in trends in diabetes. And these are some data which shows the estimates of the global prevalence and the future projections. Something that I would like to show here is that some of these data points shown below shows some projections which were made some time ago. And it had been always the case that the diabetes prevalence projections had been wrong, made wrong, because the real numbers, the real increase had been much, much more than the projections. So this is the sort of epidemic that we are dealing with. And again, these are age-adjusted rates, but I don't take too much time there. But just to highlight the importance in our context, because the highest diabetes prevalent countries in the world are in our region, as well as, they are part of our study group. So this is, again, make this also important in our context. The other important thing that most people don't consider is that the diabetes actually kills. You can see the increase in number of deaths with increasing age among people with diabetes. And then if you look at here, half of the 4 million people, this is, I think, from the previous atlas, so this is slightly, the real numbers might be a little different for the latest atlas, are young, actually under the age of 60. So diabetes kills people who are in their productive age groups. And this is particularly more so in the middle income countries that we are dealing in our study group, as well as in the low income countries compared to the high income countries. And then the other important disparity we need to recognize is the disparity of the health expenditure, where although the diabetes numbers and deaths are highest, the middle income and low income countries spend much less for diabetes for their patients. And also this, again, the diabetes related health expenditure as a percentage of gross domestic product. Again, if you look at the Southeast Asian region, this had the highest GDP, per GDP expenditure on diabetes. And again, this is our region which has fairly high diabetes prevalence when we compare to the other regions in the world. And some data from Sri Lanka, actually, these are data for Sri Lanka for 2006 based on one of our studies. And then we have not had very comprehensive island-wide or the country-wide studies in the recent times, but these data are from a recent study in Colombo. You can see here the prevalence of diabetes among those more than 60 years. is eye-watering. And even in the young people, 18 to 40 is around 12%. This is for both sexes, and then not much greatly different in males and females. And then we did another study in 2018, which was called Sri Lankan Uncommunicable Disease Study. Again, unfortunately, we were not able to do in the entire country, but if you take the Colombo district and the surrounding nearby districts, and I think most of you all know about the district where Anu is working, the Gampa district and the Kalutara, all in the western province, you see the diabetes is present in about 30%. So these are to put things in context, and which is more or less, I think, the same, I believe, particularly in urban areas in India as well as in Pakistan and Bangladesh. But if you look at the complications that can happen in people who are not well controlled with diabetes, then we are heading for another wave of complications with diabetes. And the cost, the financial cost, the human cost, we can measure by Delhi's, and then implications on the development in these low middle income countries can be much devastating. And then diabetes is chronic disease. We know particularly clinicians know the impact on the occupation of people and the leisure, hobbies, social interactions, and even sometimes these can affect their marriages. So that sort of amount of social stigma diabetes has. And then these are some data on Delhi's in Scotland, so I'm not going to detail there. So to understand how we should face the diabetes challenge, we should look at the natural history of type 2 diabetes, because it's not just that somebody gets a virus and becomes sick and die within a week or two. This is where it occurs over many years or decades, where normal people go through preclinical, or we call it pre-diabetes state. And then they develop diabetes, which we can identify by doing blood tests. Then if not controlled, they develop complications, ultimately can become disabled or die. So we can intervene at different stages. We can intervene before people get diabetes. We call this primary prevention. In fact, actually, this can even happen earlier, particularly in the children. We can intervene before they get risk factors. So we call it primordial prevention. And then when people get diabetes, if we do things to prevent complications, we call secondary prevention. And then in people get complications, if we do things to prevent disability or death, we call tertiary prevention. Now, let me take you through primary prevention of type 2 diabetes. And actually, in the primary prevention, if you look at goals, it is to prevent or delay the onset of diabetes, because sometimes you might not be able to always completely prevent the onset of diabetes. But if you can even delay on the onset, this is very, very advantageous, because that means if you delay by 10 years, the onset, then you are delaying the onset of complications by another 10-15 years, which means somebody's lifetime, they might not get really sick with diabetes. And then preserving beta cell function is also important. We will talk about beta cells as we go on. Then preventing or delaying microvascular or cardiovascular complications is another goal, which comes automatically with prevention of diabetes. And then ultimately reducing costs of diabetes care. This is also an important thing. There are two approaches we can consider for prevention of type 2 diabetes. One is the high-risk approach, where most of the studies or clinical trials has adopted this strategy, where they look into high-risk people. Usually this can be done by identifying either doing a blood test. We do call, if you have high blood sugar, fasting blood sugar, which is not normal, but not to the risk, the cutoffs of diabetes. We call it IFG, or impaired fasting glucose, or IGT, impaired glucose tolerance. If this is after a glucose drink, where the blood glucose is between 140 to 200, or else even in our eye health study, we have taken other things like central obesity is a risk factor. So different high-risk approaches can be adopted to identify people with high risk, or even if you take in US or UK, South Asian ancestry or ethnicity itself is considered high risk. So if you identify high-risk people and intervene, then we call it high-risk approach, where small numbers might be involved. Therefore, the overall cost might be less, but the effect size might be high because you already select high-risk people. In the population-based approaches, what happens is you enter target the entire population. This is really difficult because it's highly costly, and then also the effect size in a given person might be less because gets diluted. But countries like Finland is which has limited populations but with quite good health expenditure, has tried this sort of intervention. But again, it's not very easy to measure as well these population-based approaches. So these are the traditional risk factors for type 2 diabetes. I would not go into great details in all of these things, but important things all of you all know about: the family history, then the high-risk ethnicities, where the South Asian ancestry itself is a risk factor, then the sedentary lifestyle, hypertension, abnormal lipids, history of cardiovascular disease, this polycystic ovarian syndrome in women. And in some of our studies, we have identified that income and recent migration to both overseas or to urbanized areas also is considered a risk factor. Then a few groups have looked into studies to look at intervening in people with pre-diabetes, either impaired glucose tolerance or impaired fasting glucose. The Darking study is one of the earliest of such studies done in China. They have done on people with impaired glucose tolerance. You can see there had been several arms. The control arm, where nothing was done other than the usual care. Then diet, exercise, combined diet, exercise. These were the various study arms. And you can see the incidence of diabetes. There is new diabetes in the different groups compared to the control. The diet group, exercise group, and the diet plus exercise group all had lower incidence of new onset diabetes, which was statistically significant. And actually, this is a bit of a follow-up study of this Darking study, where the people were followed up for 20 years. You can see, compared to the control, the intervention group, the higher percentage remain free of diabetes. So these studies have been found to be quite impressive. And the Finnish diabetes prevention study, a similar study done in Finland by Jaakko Tammilahto and his group, again with modest interventions like more than 5% weight reduction, reducing fat, reducing saturated fats, increasing the fiber, and modest amounts of physical exercise. They showed that 58% reduction can be achieved in type 2 diabetes in people with pre-diabetes. Similar study was done in US. It's called the DPP, where the lifestyle group showed the identically same 58% reduction like the DPS. The metformin was also used in the study as an intervention, but the metformin group showed lower level of effect compared to the lifestyle. And these studies were replicated by Ramachandran's group in India. And they also showed that these sort of interventions can be replicated in South Asians in India. And we also ambitiously started this project, the iHealth, in Sri Lanka, India, Pakistan, and Bangladesh. And we have published the study protocol, where we screen people to see whether they have high risk, whether they have high waist circumference, or the pre-diabetes based on HbA1c. And then we have already done this study, and I think final data needs to be presented and written up. And you can see some important stuff on the screening population. and where the pre-diabetes, which I would like to show, is very high, generally 20% pre-diabetes in the population. And these are this is some data on the intervention cohort. Again, pre-diabetes is quite high, and it is as high as 56% in our Sri Lankan cohort. This study data will be published soon, but I'm a bit like, feeling sad in this, because we could not do this elegant study in the same way that we anticipated initially at the beginning, because of the major issues with regards to the pandemic and so on that affected the region. Now, let me take you through the usual traditional paradigm of management of most patients with type 2 diabetes. Now, there's a lot of evidence that tight glucose control, we call it glycemic control, is beneficial for people with diabetes. The greatest study is this UK-PDS study done in Oxford, and they showed that almost all complications with that occurs with diabetes can be reduced by good glycemic control. Although it was not statistically significant for myocardial infarction, death, and all-cause mortality at that time, all the other complications were significantly reduced. Now, people who treat diabetic patients know that, particularly with patients with type 2 diabetes, you start with diet, exercise, and then with one form of tablets usually, and then combination when they are unable to keep control with their HbA1c or glycosylated hemoglobin, and then you keep on adding, and then sometimes you add insulin when you cannot achieve control with tablets alone, and then when you can't achieve good control with one insulin injection, you add more insulin injection, we call intensive insulin therapy, and so on. And this is actually, you can see how complicated is the American Diabetic Association, European Association for Study of Diabetes algorithm for management of type 2 diabetes, based on whether you have atherosclerotic heart disease, CKD, whether you have hypoglycemia, whether you want to have weight loss, whether the cost is an issue. There are different types, and this is very complicated and complex, and also costly. So the traditional paradigm of management had been progressive escalation of treatment according to their control, according to the guidelines. And we usually actually we can say that this is like treatment for failure, which was elegantly shown in this study called the ADOPT, or the Diabetes Outcome Progression Study, which showed that whether you, whatever the form of treatment, it is, they have used in this studies a drug called rosiglitazone, metformin, glyburide, we call, this is called glibenclamide in our part of the world. And then whatever the treatment, initially they get good control, and subsequently all the treatment arms fail. And here they have looked into the failure of therapy by looking at the cumulative incidence of monotherapy failure. You can see, although it's at different, the magnitudes, all treatments fail with time. So all people with diabetes, when they start treatment, usually have a fear of failure of treatment. But what if we think about cure or regression of type 2 diabetes? This will really brighten the lives of people with diabetes. So we need to think whether to think of control versus cure. Now, if we compare control versus cure, now in the control, there's a bit of a attitude where somebody is lifetime sick. But if you come out of completely medications, you can have a sense of being completely healthy or absence of sickness. And also, there's always the tendency for failure with control. But cure, it's not usual. And also, a lot of studies have shown that if you have very good control, normalization of glucose in the initial part of their illness, then this has a carryover effect. We call it legacy effect. And even if the control becomes less later on, these effects persist. Then if you don't get, sometimes these people with control, they have waxing, waning periods where sometimes their blood glucose can be not that great. So they tend to get complications, but if you get more or less cure, you might not get complications. Cost, you need to think of the initial cost of the remission versus the lifelong cost of the medications, then the blood tests, and then issues that would arise with complications, then other implications, societal implications, cost of life, all can have differences when we compare control versus cure. Now, remission of a chronic disease, particularly when needs to be thought about thinking of the pathogenetic mechanisms and the risk factors. So if you look at the pathophysiology of type 2 diabetes, it's usually uniformly due to caloric excess, particularly in the background of sedentary behavior. You burn less calories but take more, which leads to obesity, insulin resistance, and in the this pathway also two other important things also plays key roles. That's one thing called lipotoxicity, where the lipids become toxic, and the glucotoxicity, where the glucose become toxic. And this is elegantly actually explained in this twin cycle hypothesis, where the positive caloric balance leads to increased fat, particularly in the liver. And we know the liver plays a very important role in the metabolism of the glucose, where most of the glucose is taken up to the liver and deposited, and also when the glucose level comes down, the liver produces glucose, and then this is an important thing. And when the liver is loaded with fat, it is thought that the liver is there is liver insulin resistance occurs. As a result, although the insulin is there, liver does not metabolize glucose properly. And then this leads to increased basal insulin secretion, and then in the pancreas to manage the glucose level. And then ultimately, anyway, with this tends to fail with also there's increased triglycerides and VLDL, which gets deposited in the islets of the pancreas. The islet triglycerides then has what's called the lipotoxicity of the beta cells, which leads to reduced insulin response to ingested glucose. And then this pancreatic beta cell failure, which happens subsequently, leads to further increase, particularly involving also the postprandial glucose. So we call this twin cycle hypothesis, with the liver cycle and pancreatic cycle, which gets affected due to the initially lipotoxicity of the liver and the pancreatic beta cells, and subsequently the glucotoxicity, as rising glucose becomes toxic to the beta cells of the pancreas. And this is also shown elegantly that the glucose is toxic to the beta cells. In this experiment, they have shown that when you treat with either diet, sulfonylurea, or insulin, whatever the mode of therapy, when you get the glucose down, this is the comparison after therapy and the before therapy, you can see the plasma insulin level increases. So this shows whatever the treatment, if you get the glucose down, your beta cells start acting better. So there is some glucotoxicity is evident from this. And particularly in when diabetes was discussed a few decades ago, people thought that in type 2 diabetes, with time, the beta cells undergo apoptosis and cell death. But with the recent studies, which I'm going to show you, with particularly bariatric surgery and then other remission strategies, the concept of beta cell death is going away. And people think that there are multiple mechanisms or models for beta cell failure. One thing is that there can be de-differentiation or loss of identity or trans-differentiation of the beta cells. That is why some of these beta cells might be redifferentiated to produce more insulin when you get the metabolism corrected with either bariatric surgery or with significant weight loss in the remission studies. And also people think that oxidative stress with glucose and the resultant mechanisms might lead to dysfunction of the beta cells. And also some still also believe that there might be some amount of beta cell death with all these processes. That is why, because particularly people who have diabetes for many years, generally the remission has been not as great as people with a short duration of diabetes. So this is an important thing. So can type 2 diabetes actually be really be reversed? Is there evidence? Let me now take you through these data. And actually, in these processes, people have come with some definitions of what is meant by their remission. They think that the partial remission is when the glycemic levels are below diagnostic threshold for diabetes, and they are not on active pharmacological treatments, and there has to be at least 1 year's duration. But even people with pre-diabetes can be here. Complete remission is when the complete normalization of glycemic measures for at least more than 1 year happens, and then not on treatment. And people called prolonged remission when the complete remission is for at least more than 5 years. But recently in 2021, there had been some change. There's a consensus group working on this definition, and they have come up with this revised suggestion where a return to glycosylated hemoglobin less than 6.5 or other comparable glycemic targets like the fasting blood glucose less than 126, or the estimated glycosylated hemoglobin based on the continuous glucose monitoring data also suggests less than 6.5 also can be taken, but without a time limit. So these are being discussed by these expert groups, and so there are change in definitions as well. So the first evidence for the possibility of reversing type 2 diabetes came from these bariatric surgeries, which was actually performed initially for very severely obese people, but subsequently started for people with type 2 diabetes who was very difficult to control even with insulin. And here, this is a similar study where 60 underwent randomization either to have medical therapy. Then one form of bariatric surgery is called biliopancreatic diversion, and another form called Roux-en-Y gastric bypass. And then you can see, compared to medical therapy, those who had gastric bypass or the more aggressive biliopancreatic diversion, more or less they had normalization of their HbA1c to normal level. And then if you look at the diabetes remission at 2 years, you can see about 75% of the people who had gastric bypass and about 95% of those who had biliopancreatic diversion remained non-diabetic, or they had remitted. And then there are a lot of other studies. You can see, I don't want to go into details in all of these, has shown that bariatric surgery is very effective in reversing type 2 diabetes. But there are a lot of limitations. You can get a lot of issues with regards to people with diabetes. Some of them can have very significant other comorbidities, and the fitness for surgery can be an issue. They can develop complications due to surgery or severe weight loss, like nutritional deficiencies. And for the place for mild and moderately obese people with diabetes is still controversial, and particularly in terms of cost, particularly in countries like us, and also the acceptability, societal acceptability of surgery. Now, let me take you through this concept of reversal of glucotoxicity. Now, people started to think when there's very acute reversal of glucotoxicity by normalizing glucose level by insulin in people with type 2 diabetes, whether this might be possible to reverse type 2 diabetes. So in this study, they looked at a small number of people, treatment-naive people. They were put on multiple daily insulin doses, and then you can see the treatment affects the insulin secretion area under the curve. You can see before insulin treatment and after, and at 1 year, there's marked improvement in the insulin secretion. And so This is irrespective of any change of the body mass index. So these studies showed that here again, there's a comparison of insulin secretion and glucose response. This is showing before insulin therapy and then immediately after and at 1 year. You can see at 1 year, those who were given insulin, they had marked improvement on their insulin secretion curves and the reduction of glucose curves. So these studies looking at initial intensive insulin therapy showed that you can reverse diabetes by reducing or reversing the glucotoxicity. And here this study shows the effect of insulin compared to oral hypoglycemic agents. Insulin had been given by two methods: continuous subcutaneous insulin infusion and multiple daily injections. And you can see particularly in this aggressive form with the continuous insulin infusion, more people had been in remission in this group compared to those with oral therapy. And then again, there had been several studies on insulin use for remission, these are more or less same to what I have already described. Now, let me take you through the non-surgical, non-pharmacological interventions. The DIRECT study was a landmark study that looked at the possibility of reversing type 2 diabetes. And here it was a well-structured study done in UK in the primary care settings. And you can see this is a part of the UK where the study was done. They took 26 practices as controls and 23 practices as interventions. And these are some baseline data on the BMI and the age. 280 participants from 30 practices were involved, and their type 2 diabetes duration was less than 6 years. And then their endpoints was weight reduction more than 15 kilograms or A1C coming into non-diabetic levels at 1 year. And subsequently, they were followed for another 2 years. Again, some baseline data, 59% were males, quite sort of overweight or obese group. And then about 75% were on the medication, both in the control and the intervention arms. And the A1C was also in the diabetic ranges. And here what happened was that their treatments were withdrawn. Quite an ambitious study, the treatment was withdrawn, and they were started on total, diet replacement for a period of 3 months, where during this period, they lost quite a lot of weight. And then this food was reintroduced gradually, and the weight loss was maintained for about 24 months. And then here in the total diet replacement, they use a commercial micronutrient replete to give about 800 kilocalories per day. And then these are the data. 16 had withdrawn, and sometimes it's not very easy for everybody to do follow these. 86% attended 24 months review, and data was taken from the GP records for non-attendees. Therefore, 91% had data available. Let me take you through some of the outcomes. The weight loss outcome was 15 kilograms. The A1C less than 48 millimoles. And this was published, you can see, at 1 year and 2 year in the control group, about 3 to 4% were able to come into a remission. But in the intervention group at 1 year, 45%, and at 2 years, 35% was in remission. So the other important thing that came out in this study was that if people lost quite a lot of weight, like if they lost more than 15 kilos, quite a number, 86% was able to be in remission compared to 0% if they did not lose any weight. So this is another important thing where they showed that the coming into remission as well as maintaining in remission was also quite correlated with the weight change. And you can see the people who went into remission remained in remission, and the people who did not remit, the weight was a very important significant factor. And then here you see the medication use at baseline 24 months in the intervention group as well as the control group. So the intervention group, many of the people came out of their medications compared to the others. And the HbA1c is seen in the right-hand side graph. So they also looked into who achieves durable remission. They found that the remission was more likely when there's increased weight loss, which I have already alluded to. And then particularly also weight loss is from 12 to 24 months. And then also was shown that people older age group was also slightly more likely to be in remission, and the males. So it is not just that everybody smoothly went into remission. Some people actually relapsed during this process, and then they had to have also relapse management using more aggressive methods, including behavior strategies. So in summary, here the 36% of the intervention participants sustained remission at 24 months. HbA1c was significantly reduced. And then with 50% reduction in the use of medicines, durable remission of short duration type 2 is attainable, particularly in the primary care setting. And in addition, they also showed favorable changes in the blood pressure, lipids, adverse events were less, and the quality of life was shown to be significant in those who remitted. Here data for blood pressure, I don't want to go into details here because of the interest of time. Lipids, favorable response. Then adverse events were less in people who were in the remission program, both in terms of the sudden death, the CVA, although these are not statistically significant, the adverse effects were not common in the intervention group. These are the data for quality of life. Now, another important concept that I would like to show here using this MRI, I think spectroscopy or something like that technology they have used. Here you see before the intervention, the amount of liver fat, and the dark shape is when the fat is removed. You can see the removal of liver fat is thought to be an important thing in achieving remission. And again, there's a comparison of the change of liver fat and also pancreatic fat. These people who are fairly good in radiology might notice there's both reduction of liver fat as well as pancreatic fat by weight loss. I would not go into great detail in this study. A similar study called Look Ahead study was also done to look into the effect of possibility of remission of type 2 diabetes by intensive lifestyle intervention. You can see different time frames, number of years, people compared to those with who had only diabetes support and education. Those in the intensive lifestyle intervention, a lot of them were in diabetic remission. So this is again more data available on this concept. And then in addition to these, several other studies also have looked into the effect of very low caloric diets for diabetic remission. And some studies like this one by the LIMS group, they have looked into possible mechanisms, and they have looked into responders and non-responders and controls and compared the three groups. You can see the body weight, particularly both the responders as well as non-responders compared to controls have had loss of body weight. And then only the responders responded with reduction of HbA1c and fasting blood glucose, as it is more or less expected from the definitions. But if you look at the liver fat and then the VLDL production rate, and then the plasma VLDL1 triglycerides, and then fasting plasma glucose, and particularly in the group with pancreatic fat, who had reduction of pancreatic fat, has shown the most important reduction of the blood glucose as well as the improvement in the coming into remission. Here are some data showing the change of the beta cell response. The first one shows first phase insulin response in the responders. You can see the responders had the highest insulin response both in the first phase as well as maximum insulin secretion compared to non-responders as well as control. So again, this shows that the reversal is important happening in those who get most effect on the pancreatic fat, and that is the group who gets the reversal of the beta cell activity by increasing insulin. So what are the practical issues that were shown in remission strategies in these large multi-center studies from the West? The cost for prevention or remission for one patient is quite high, and then large patient turnover in countries like us, with lack of dedicated staffs, wards, facilities, and also on the cultural aspects of adhering to a diet, particularly liquid diet sort of measures, which we don't know whether may be applicable and acceptable to populations in the South Asia, are things that we need to consider. So in our experience, we did a limited, actually, this is an audit, not a randomized control study. We wanted to try out this in about 283 people with diabetes, recently diagnosed diabetes, but about 100 of them, they were not subsequently contactable, and they were not happy to take part in the program. And about 181 participated. Subsequently, about 11, we did not get the feedback. Feedback was received from about 170. And out of that, about 51% had followed the program. And then about another, 50% did not follow. And in out of the 87 who followed, about 55 had remitted, which is about prevalence of the effect of about 63%. Of those who followed has remitted, and then some of them has subsequently relapsed and then re-remitted as well. So these are the characteristics, clinical parameters, and then at enrollment, you can see very high HbA1c, and then you can also see their body weight, female 73, overweight or obese in terms of South Asian, cutoffs, males 87 kilos. And these are some outcomes from the program. And here you see in females, about 25% had followed and remitted, whereas in males, about 35% has followed and remitted. And then, so this is actually, if you take the number who really followed and then remitted, which is the percentage is about 60%, is quite impressive in a just busy clinic with not much, facilities for calling people, following up very closely, giving behavioral therapy and so on. So these are some preliminary data in our experience from on diabetes remission. Again, data on the weight, body weight, at enrollment, at the end, quite significant, about 10% weight loss who followed the program, both whether they did not, even in people who did not follow, they also have had some weight loss, useful weight loss. Then the A1C has markedly come down in the people who had followed up. So is the blood glucose. So now the other experience that we had in our work was that actually we used a combination method where we were quite, not very comfortable, particularly to completely put on diet in people who comes with HbA1c of about 10 or above, and then also having very high blood glucose levels. So we used a hybrid model here where we used both. If the blood glucose was very high, initial period about 2 weeks of intensive insulin therapy to reverse the glucotoxicity, and also used in our study metformin and actually sitagliptin, which are generally weight neutral, or metformin is even having some negative effect on the weight. So similar to our work, also there have been some studies looking at the use of metformin, acarbose, and then glargine, insulin for similar effects. And here again, this diagram also from this Taylor is one of the authorities on diabetes prevention with Rory Horman. They have shown that different approaches can be adopted based on the body mass index. If the body mass index is very high, like the BMI more than about 40, you might have to think of weight losing medications like metformin, and then people with diabetes therapeutic knowledge knows the GLP-1 receptor agonist and SGLT2 inhibitors can be used for weight loss, to enhance weight loss. And then insulin might also help in reversing glucotoxicity. And then when people are very not so overweight or obese, then in short intensive insulin, because you might not be able to get them to lose a lot of weight. So these are different approaches that we may be able to think about when thinking about more pragmatic approaches for diabetes remission or reversal. Then comprehensive programs should have supervision by experts, experienced people, then individualized plans, as I showed earlier. Then you need to provide education, resource. Sometimes you might have to give meal plans, exercise plans, personal guidance. Sometimes it's very important to improve the compliance with the help of nutritionists, trainers, behavior therapies. Sometimes apps might be very useful, like mobile apps and hotlines, care lines, and also having patient groups to self-motivate, group therapies. These are all important suggestions to comprehensive remission programs. So this is, I think, my last slide. In summary, the current paradigm of management diabetes involves a treatment for failure approach. And there's a lot of evidence exists for primary prevention of type 2 diabetes. And also there's good data on reversibility, possibility of reverse type 2 diabetes, both surgical and non-surgical methods. And we also have got some limited experience. We need to also rethink of the management strategy, especially of the recently diagnosed patients with diabetes, because particularly every day when we in our clinics, we see dozens of patients who are coming newly diagnosed. So are we going to put all of them into pharmacotherapy for the rest of their lives, which amounts to enormous costs for the patients, for the society, for the already struggling economies? So we need to rethink whether we need to focus from just mere control to the reversal or the remission of at least people who are possible to follow this sort of method, where if they follow, we can show them that more than about 50% can go into remission. So we need to have undertake more research, particularly in our part of the world, to look into doing larger studies, feasibility, and also identifying factors, both the individual patient factors and other factors would make such remission programs more successful, so that we can adopt our programs in such a way. So we need to think about this cost effectiveness, and also evidence is very important in providing care. And I think we just had the World Diabetes Day recently. So I think this is very important topic that we discussed in such an environment.